Well, good afternoon. It's the end of the day. I'll try to keep you awake with some interesting stories. Radiation is one of the main modality in the treatment of cancer. What I'd like to do is over the next 25 to 30 minutes go over some of the fundamentals of radiation oncology. The global burden of cancer has continued to increase. It's mostly because of the aging population, increase in population, as well as the cancer-causing behaviors like smoking. Globally, approximately 12.7 million cancers are diagnosed every year, and approximately 7.5 to 7.6 million people die of cancer. The most common cancer globally is lung cancer in men, and there's the most common cause of mortality in males. In women, breast cancer is the most common cause of cancer, and similarly the most common cause of mortality. In economically developed countries, at least in male, the prostate is the most common cause of cancer. So again, what I like to do is, I'm sure Mark and Leo has discussed about chemotherapy and biological agents, and Dr. Khan probably talked to you about the surgery. I'm going to concentrate on radiation therapy, and I'll go through the physical basis for radiation oncology, the biological basis, and touch base on some of the clinical applications of radiation oncology. So in 19th century, there are four major discoveries that really changed how the medicine is practiced. It took the medicine out of the dark ages. One of those was discovery of anesthesia, discovery of antiseptics, discovery of germ as the causes of illnesses, and discovery of X-rays. The X-rays was first discovered by Röntgen in 1895. And he received Nobel Prize for that in 1901. Right after the discovery of X-rays, within a year or two, there were approximately 100 different illnesses that were treated with radiation, ranging from dermatitis to psoriasis to syphilis. Radiation was also commonly used for the treatment of cancer. At the same time, when X-rays were discovered, Marie Curie, who migrated from Poland to France, discovered radium from pitchblende, as well as polonium. And polonium is probably the only radioisotope that's named after a country, because she came from Poland, so she named it polonium. She also coined the word radioactivity, and she received 2 Nobel Prizes in 1903 and 1911 because of her discovery of radium and radioactivity. It's interesting, her daughter Irene also got a Nobel Prize. The type of radiation that's being used in radiation oncology for the treatment of cancer is called ionizing radiation. It's a radiation that has sufficient energy to eject the orbital electrons from the atom. And while doing so, it causes a localized release of large amount of energy. There are 2 types of ionizing radiation. One is electromagnetic, second is particle radiation treatment. Electromagnetic radiation, as you might know, was described by Maxwell as the oscillating waves of electric and magnetic fields. And there's a range of electromagnetic radiation depending upon the frequency as well as wavelength. Particles are also used for treating the cancer, and they can deposit large amount of energies in patients. So electromagnetic radiations are indirectly ionizing. When a large amount of energy is deposited, you produce secondary electrons through pair production, Compton interaction, or photoelectric interaction. There are 2 kinds of electromagnetic radiation. One is X-rays, which are produced in high voltage in vacuum tubes where electrons are accelerated and hit on the target consisting of tungsten or gold, and X-rays are produced. Gamma rays are produced intranuclearly through decay of radioisotopes. And there's a simple relationship between the energy of electromagnetic radiation, frequency, and wavelength. In particle radiation, the most common particle radiation that's commonly used are the electrons. These are small, negatively charged particles that has finite range and that can deposit large amount of energy when travels through the tissues. The other commonly charged particles that is used for radiation is proton particles. They are much heavier than electrons, approximately 2,000 times, so they need large accelerators to accelerate them before they can be used for treatment. Neutrons are also used for the treatment of cancer, but the most commonly used radiation that are used are electromagnetic radiations, electron particles, and proton particles. We have to be able to quantitate the doses of radiation to be able to deliver radiation effectively and consistently. So radiation is described, the unit of radiation is described previously as rad. So in certain books you might read rad, which essentially is absorbed dose in the tissue that corresponds to energy absorption of 100 ergs per gram. While 1 gray, which is the most commonly used unit for absorbed dose, is the energy absorption of 1 joule per kilogram. Just as there's a simple relationship, 100 rad is equal to 1 gray. Briefly about the biological basis of radiation, there's a very strong evidence that radiation damages the cell through the destruction or through the impact on DNA in the chromosomes. There are two mechanisms radiation damages the cells. One is called indirect action, where the secondary electrons are produced that interacts with water molecules in the tissues and produce free radicals that causes damages to the DNA molecules in the chromosomes. Second is where the secondary electrons directly damages the DNA. Most of the high LET radiation interacts in the tissues through direct action, while most of the low LET radiation interacts in the tissue through production of free radicals. As Dr. Agulnik was pointing out, radiation, the cell death is dependent upon the phases of the cell cycle. Radiation is most effective in the mitotic phase of the cell cycle. So this is a semi-logarithmic scale where you have a survival curve on one scale and radiation doses on the other scale. Again, radiation is the most effective in mitotic phase of the cell cycle and least effective in the late S phase of the cell cycle, while the G1 and early S phase of the cell cycles are kind of intermediate. What's interesting is radiation is also very effective when the cells are oxygenated. So you need 2.5 to 3 times of radiation to kill the cells if the environment is hypoxic environment, which is pretty much the same graphs as shown here, that the cells are very sensitive in oxygenated environment as compared to hypoxic environment. It is also dose dependent. At high dose rate, the oxygen enhancement ratio is 3.5 times, while at low dose range is 2.5 times. Now, in early 20s and 30s, radiation was given in a single fraction, 1 or 2 high dose of radiation. And what was observed was there was very high toxicity while the tumor control rate was very low. So one of the French scientists, Regards, did an experiment on ram's testicles. And what he did was he used a high dose of radiation given in 1 or 2 fraction versus protracted course of radiation. The same amount of radiation was given over 10 to 12 fraction. And what he observed was that he was able to sterilize these RAMs when he fractionated the radiation treatment as compared to when the radiation was given in 1 or 2 fraction without causing any toxicity. So the modern radiation therapy is done in fractionated form. A typical course of radiation is 1 treatment every day, 5 to 6 times a week for a period of 6 to 7 weeks. So there are 4 hours of radiation biology. One is called repair. So essentially when you are fractionating the radiation, you are getting preferential repair of the normal cells, because normal cells tend to get repaired from lethal and sublethal damage much more efficiently as compared to the tumor cells. Reassortment of the cells occurs in both normal cells as well as the tumor cells. However, it seems to benefit the tumor cells, or it seems to benefit the normal cells more than the tumor cells. The repopulation of the cells also occurs between the fractionation, and I think that's preferentially, it preferentially helps the tumor cells as compared to the normal cells. And reoxygenation of the cells seems to occur only in the tumor cells. The doses of radiation also varies upon the histology of the tumor. So in cell survival curves, if you see lymphomas are the most sensitive tumors, you can control most of the lymphoma in 30 to 40 grays, as compared to glioblastoma that you really need 70, 80, 90 gray, and even then you're not able to control these tumors. So I'm going to briefly talk about the clinical applications. So we talked about the physical aspects, some of the fundamentals of physical basis for radiation oncology, some of the fundamentals for biological basis for radiation oncology. So let's discuss some of about the clinical applications of radiation oncology. Radiation is used in approximately 60% of all the cancer patients at some point in time. It can be used for curative, for the cure of cancer, let's say for example lymphomas, germinomas, head and neck cancers, colorectal cancer, practically any kind of cancer you can use radiation treatment. I mostly treat head and neck cancers and lymphomas. Our control rate for head and neck cancer stage 3s and 4s about 2 decades ago was in the range of 30%, which is close to 60% now, 60 to 70% now. And this is because of the effectiveness of radiation as well as chemotherapy in the treatment of these tumors. Radiation can also be used for palliation, for pain, bleeding, and obstruction of the bronchus. In certain benign conditions, we also use radiation treatment, particularly meningiomas. We have used radiation for coronary arterial stenosis and trigeminal neuralgia. It's very interesting. In trigeminal neuralgia, we can target the trigeminal nerve at the skull base within 3 to 4 millimeters, 3 to 4 millimeters in size, and we can give 70 to 80 gray in 1 fraction and help these patients relieve their pain due to trigeminal nerve. Radiation can be delivered through brachytherapy or teletherapy. Brachytherapy essentially means that radiation sources are in close contact with the patient or the tumor, or they're inserted in the tumor. In teletherapy, radiation is delivered from a distance. There is no contact of the radiation machine or radioactive sources or radiation to the patient directly. So this is an example of a high-rate brachytherapy where the iridium-192 sources are stored. We use this particular approach for treating gynecological cancers, prostate cancers, gastrointestinal cancers, and pulmonary cancers. This is an example of breast cancer that's being treated with brachytherapy. In the past, this patient will receive 7 weeks of treatment one treatment every day. But with proper selection, you can treat these patients in, excuse me, in 2 or 3 sittings using the high dose rate brachytherapy, which is inserted in this balloon at the tumor bed. Over the past 3 decades, radiation has evolved from 2-dimensional treatment to 3-dimensional radiation treatment, or intensity modulation radiation therapy, which essentially tailors the radiation beam and the radiation fluence to target the tumor and decrease radiation to the surrounding tissue. You could image the tumors in real time when you're giving radiation to these patients. You can use volumetric modulated arc therapy. So instead of using step and shoot technology, you can, in one rotation, you can treat the entire tumor in a very short period of time. And I'm going to briefly talk about stereotactic body radiation therapy as well as radiosurgery treatment. The concept here is that you're able to target your radiation much more precisely and delivering small amount of radiation to the normal tissues. Just to go over the step of the process of radiation treatments, when the patient comes for radiation treatment, the first process is planning. And in order to plan these patients, we scan these patients. So we have several CT simulators in our department that has special features for planning purposes. Once the patient is scanned, so these are some of the scans of the patients, we will draw the volume that we would like to treat on these patients. And after the volumes are drawn, the physicist runs the isodose plans for these patients. So let's go over this patient. So GTV means the gross tumor volume. So this patient has a large tumor that's located in the orbit and the skull base right here. The green volume includes taking account uncertainties in setup of the patient. So if you look at these doses, the opposite eye is getting only 15 gray, while you can give 63 gray to the tumor. So essentially, by using inverse planning, you can give a very high dose to the tumor and decrease radiation to the normal structures. This is a graphical presentation. So if you look at these numbers here, let's talk about the left parotid. If you use conventional radiation treatment, you'll be giving a mean dose of 4,000 centigrays. While using intensity modulation radiation therapy, you can decrease dose to less than half. So essentially, you can do the same thing with practically most of the normal tissues without compromising the doses to the tumor. So external beam radiation is delivered either through linear accelerators, where the electrons are again accelerated and they're impacted on the target, and X-rays are generated. All of these LINACs have digital platforms, and they combines true 3-dimensional image guidance at the time of treatment, and very highly conformal beam is being delivered. The table on this LINAC has 6 degrees of freedom, so you can move you can adjust the patient's position in X, Y, Z, pitch and roll, and yaw position. So you have 6 degrees of freedom. And you can really target your radiation very precisely. So I'm going to briefly show you a video. I think you'll enjoy it. Essentially, these are called MLC, multi-leaf collimator. They are inbuilt in the head of the machine. And this is how the beam's eye view is looking at the tumor. This is tumor right here. So essentially, you can program your computer through using the inverse planning and target your beam very precisely to the tumor. And you can see the multi-leaf collimator moving, and it's just exactly where you want to target your dose. We'll show you the beam arrangements. So you have the first beam coming in, second beam here, third beam, fourth, so the idea is, again, using multiple port, you can really target your radiation and decrease radiation to the normal structures. A brief word about gamma knife. Gamma knife is used for intracranial radiosurgery, brain tumors, metastasis to the brain. We have the fourth generation at Northwestern. The first generation we bought was in 1989. It has a very novel collimator design. It has 192 cobalt sources, and it can produce dynamic field shaping. So all these cobalt sources are mounted in sectors. So there are 8 sectors in the gamma knife, and you can very precisely radiate the tumor within few millimeters. So within few millimeters, you can have 100% of the dose, and 2 or 3 millimeters away, you can have 50% of the dose. So it's an extremely precise technology. So here it shows you the process of how the gamma knife is delivered in these patients. So the here patient is fixed in the frame and is moved into the helmet of the gamma knife. You can adjust the patient's position any way you like. Now it's all automated from outside. So these are the various sectors where the cobalt sources are mounted. So you can use multiple lesions at the same time. You can radiate. So to give you an example, this patient is a 26-year-old patient who had Ewing sarcoma of the clivus. The patient already has had radiation treatment, so the brainstem and the spinal cord were maxed out. By using gamma knife at the skull base, you can see, you can shape your beam any way you like. So you can deliver high dose of radiation to this area while decreasing radiation to the brainstem. Just to give you some clinical results with gamma knife, depending upon the histology, and we can use for benign conditions like arteriovenous malformation. You can have control ranging from 70 to 90%. Same is with meningioma, depends upon the grade of the tumors. For acoustic neuroma, again, 90s craniopharyngioma, pituitary adenomas, low-grade astrocytomas. So the control rate, if you properly select your patients, is extremely high by using this modern technology. Just a brief word about the proton beam. The main difference in the proton beam is, let's say, for example, the tumor is located at a depth of 20 centimeters within the tissue. With a photon beam, usually the maximum amount of energy is deposited depending upon the Dmax, about half to 1 centimeters, and there's an exponential decay of radiation treatment. In the proton beam, you have small amount of energy, and the maximum amount of energy is deposited where the tumor is located. So you are able to save some normal tissues here as well as some normal tissues here. However, some of this benefit You can, if you use multiple fields and intensity modulation radiation therapy, you could practically deliver same kind of radiation with intensity modulation radiation therapy. So this is an example of patients treated with three-dimensional conformal radiation therapy, intensity modulation radiation therapy, and three-dimensional proton treatment. Again, the idea is to give the maximum amount of radiation to the tumor and a minimum amount of radiation to the normal tissues. This is an interesting example. It shows you how you can really stop radiation treatment. This is a patient with medulloblastoma who was treated to the spine using the proton beam, and you can see where the beam stopped. So there is no radiation anterior to the vertebral body, so there is least amount of radiation to the normal structures. Again, these are some of the clinical results in adults. Using the proton, you can have uveal melanoma. Again, these are selected patients, choroidomas in the range of 80 to 90%, depending upon the tumor type. Again, for lung cancer also, you can get, for early stage lung cancer, again, you can get the same kind of results with photon treatment also, with high dose of photon radiation treatment. These are some of the clinical results in children. That medulloblastomas, survival is 70 to 80%, ependymomas 50 to 70%, rhabdos 70 to 80%, Ewings 70 to 80%, worms approximately 90%. So in conclusion, radiation plays an important role in the treatment of malignant tumors. It's a rapidly changing field with advances being made daily. Since my residency, I started my residencies in 1977, and I've seen tremendous changes in the field of radiation oncology. For patients, cures have gone up 2 to 3 times than 3 decades ago. The toxicity has gone down substantially. The technology has been very remarkable, and this is just not because of radiation only. It's also a combination of chemotherapy and targeted therapy, with Dr. Gordon and Mark talked to you briefly. Well, thank you very much. I'll be happy to answer any questions from you. Yes. It really depends upon the tumor type, the tumor stage, patient. To give you an example, if somebody comes with a T1 cholangiocarcinoma, and the patient comes to me, I will recommend radiation treatment because the control rate is in the range of 95 to 98%. With no surgery, with preservation of voice, the voice quality is excellent in these patients. But within a category of T1 lesion, there could be a selected T1 lesion that you could use laser to remove this treatment. So you could do the surgery in one sitting instead of patient coming every day for the next 6 weeks. So I really think it really depends upon so many variables that you have to take into consideration for each patient. So it's patient specific and the tumor specific. Yes, sir.
I have a couple questions.
Sure.
Is that gamma knife just for head and neck?
The gamma knife is mostly for head and mostly for brain, actually, brain and skull base. It's not all the head and neck tumors because the limitation is you can go up to C1 or C2. So it's mostly for intracranial lesions.
My other question was, did you say that you were able to determine in real time tissue that had been repurposed or successfully treated?
No, you can't do that. You can't. What I was saying is you can image while you're treating a patient. There are diagnostic equipment that are mounted on the machine. So you can CT scan these patients during the treatment. So essentially, let's say if you're treating a prostate cancer and the prostate moves during the treatment, so you can see how much prostate has moved during the radiation treatment. So, and you can adjust your fields. So in real time, you can image the patients and adjust the patients, although it can be time consuming, but you could do it. Because necrosis takes months to years to happen, really. Okay, thank you again. Yeah.